So as you all know, ThedaCare has been committed to protecting the health and safety and keeping our communities informed of the evolving situation and its impact on our communities and at ThedaCare. So because of our dramatically rising levels of COVID-19, ThedaCare is seeing a record number of COVID patients in our 7 hospitals. And throughout our system, we have today approximately 94 COVID patients admitted. And that number is rising because I saw some yet in the emergency department that look that they need to be admitted yet, which is more than any time we've had during this pandemic. So these are our highest levels. And our current forecast model predicts that these cases will continue to rise for the next 2 to 3 weeks. And this, as you all know, is highly transmissible. Omicron variant spreads rapidly in northeast and central Wisconsin. If you could go on mute if you're not, thank you. A little background noise there. And our hospitals are full and the wait times are long. So I'll give you just a few statistics so that, to help with this message today. So about 80% of our COVID patients who have been hospitalized or in the ICU during the pandemic have been unvaccinated. And according to the Wisconsin Department of Human Services, people not fully vaccinated against COVID-19 were 14 times as likely to die, and 9.5 times as likely to be hospitalized, and 3 times as likely to test positive from those who are vaccinated. And that is from our December data. The report released Friday shows that for every 100,000 unvaccinated people, almost 51 die, 176 were admitted to the hospital, and 4,746 tested positive. So for fully vaccinated people, those numbers were 3.6 deaths, 18.5 hospitalizations, and about 1,573 cases. So as you all can see, dramatically different. And so those statistics represent a time when the Delta variant was mostly dominant. And so we know now with this new variant that those numbers are likely to be significantly different. So I'm going to turn it over to Dr. Hooker, and he is going to talk about the decision that we made in regards to our surgical cases.
Right. Thank you, Lynn. Good morning, everyone. For all the reasons that Lynn just outlined, we made a decision towards the end of last week that we were once again going to have to pause elective surgeries that require a bed post-operatively. Again, that a lot of thought and preparation goes into a decision like that. Obviously, lots of impact to our patients and community when you pause surgeries like this. We've been working with the team of surgeons, emergency department leaders, hospitalists, administration, leaders from ThedaCare to really have a conversation, sometimes on a daily basis, sometimes several times a day to decide when the timing is right for this. And so as of today, ThedaCare is pausing all elective surgeries that require a bed post-surgically. Now, we cannot shut down our operating rooms, across the system. Obviously, there's a lot of implications to that. So we still will continue with emergent surgeries and surgeries that we consider time sensitive. So for example, cancer surgeries cannot be delayed for 4 weeks because of that direct impact on patients. So, we don't consider those in the elective realm. We consider those time sensitive, and we have mechanisms to proceed with those surgeries. So that's really the announcement for today, is that we're pausing those surgeries. We continue to meet regularly. We continue to reevaluate. If we need to start standing down other services, other levels of surgery, then we have that conversation with our physician leaders and ThedaCare leadership and make those decisions kind of on the fly. I mean, we've learned to adjust rapidly to changing situations, and have a very targeted response to this that we're hoping will allow us to continue to take care of those patients that need acute care beds for our communities. All right.
Thank you so much, Dr. Hooker. Appreciate it. Okay, so we will be taking questions now. And I do have some coming through the chat. So again, if you have a specific question for either Lynn or Dr. Hooker, please send me a message and then I will call on you and you can ask your question. Let's start with Fox 11. Fox 11 has a question about surgery. So Dr. Hooker, this one is probably for you.
Thank you. Two very good questions. So some examples, and probably the largest single group for an elective surgery would be things like total joint replacements. So those that are getting a total knee replacement or a total hip replacement, while that surgery is certainly necessary and has an effect on a patient's ability to function, it's not considered an emergent surgery that has to be done on a very set period of time. So that surgery, for example, a knee surgery could be delayed for 3 or 4 weeks or even longer if we needed to allow us to have the capacity to take care of those surgeries that are, not elective. So again, not elective surgeries would be our trauma patients that come to us, acute fractures on the orthopedic side, cancer surgeries where you really can't delay a surgery for an extended period of time because of the direct impact on patient care. As far as an algorithm, we have tried creating algorithms over the past 2 years and learned that you really can't have a definitive algorithm to determine when to go back live with elective surgeries. There are just too many variables. The new variable that we're dealing with this time around with the surge is not only are we having these increased volumes, we're having significant issues with our staffing. So we have to look at the COVID inpatient volume, what our staffing levels are, what our testing supply is. Our OR teams are also getting sick with COVID, and our care providers are getting sick. So not only do we have staffing shortages, we have employees and team members that are out with COVID on either isolation or quarantine. So all those things kind of go together, and we meet daily to say, okay, today we think we can plan to go back live with elective surgeries 48 hours from now, or maybe 72 hours from now. So it's really just coming together and having a conversation frequently rather than having defined numbers or definitive algorithm to go back live. So I hope that answers your question.
Thank you, Dr. Hooker. And it looks like a few of our questions coming in are very similar to when we would be resuming surgeries. So WBAY, WHBY, I know that was similar to your question as well. So if you have something else to ask, please let me know and we can call on you as well. Let's go to Kelsey right now with NBC 26. She has a question. Kelsey.
Hi, thank you so much for taking my question. So just with everything going on and knowing that there's a spike in cases coming, I was wondering if you guys have a strategy in some of the areas and rural counties where vaccination rates are a little bit lower to prepare for this incoming wave, especially when hospital beds are so limited right now.
So, we continue to promote vaccinations as sort of our frontline defense. I think we all know vaccinations are not 100% preventative to become ill with COVID. But as the numbers that Lynn shared with you, they're extraordinarily protective when it comes to requiring an admission to the hospital, when requiring an intensive care unit bed, and then mortality or death. They're very effective at helping prevent those aspects of the surge. We have vaccination clinics that are set up in rural communities. We continue to reach out multiple times a day with communications from leadership and physician leaders to continue to encourage vaccinations. We still are offering multiple vaccination clinics. The numbers have kind of trended off somewhat. I think, it doesn't take a statistic expert to notice that those that have wanted to get a vaccine have been vaccinated. So really it's trying to work through and educating for those that have had some resistance, and seeing the surge that we're in actually has driven some increased compliance with getting vaccinations again. So it's just an ongoing effort to really encourage this and looking at the numbers as we have that data come in, really showing how protective they are for patients, and especially patients that are at high risk with comorbidities.
Thank you, Dr. Hooker. Lynn, did you want to add something as well?
Dr. Hooker said exactly what I was going to say. So nope, I think we're all set.
Great. All right, it looks like we have addressed most of the questions. Any other reporters or outlets? Again, we did notice that some of the questions coming in were very similar to when we would resume those surgeries.
Sandra, I'm going to ask a question. It's Emily. It's just the chat box pops up and I'm recording on my end, so that's why I don't like
Sure.
this messes up my recording. But can you just, I know there in the news release it even sort of talked about this. I mean, is it a staffing shortage? I mean, there's enough beds in the hospital, obviously, right? It's more of a staffing shortage is what's leading to this and to keep people out of the hospital to prevent other people from getting sick.
It's actually both. So yes, the staffing challenges with our staff being ill, or just the national, labor shortage, obviously is not helping the situation. But some of our units are full. Our COVID units are full, and we had to open a second unit at Nina as of Friday. So it's actually a combination of both, depending on the unit.
For the COVID unit, you're not necessarily doing surgery. My husband works in healthcare, so he's like, we have beds in our hospital. He's like, we just don't have the staff to take care of these patients. So
That's a fair question. So I'll just use Nina as an example. So on the 6th floor, that's our surgical unit. We've had to make half of that unit our new COVID unit. So our second COVID unit for this hospital. That means we don't have the beds for these surgical patients. So these COVID patients are consuming beds that we would have then used for our surgical patients. And we need that surgery team to be redeployed to care for these patients as well.
Thank you, Lynn. Very helpful explanation there. Okay, it looks like one other question from Fox 11.
So when we paused surgeries in the past, we had ended up pausing for around 6 weeks. And this time around, we're being much more focused on assessing every day. I don't expect that we're going to have to pause that long. I think it'll probably be closer to, a week or two, maybe 3 weeks, to kind of mirror the expected peak in the surge that Cassandra just shared and Lynn shared. So I can't give you a concrete number, but I would expect approximately 2 weeks that we would have to pause. But, if we see a miraculous drop off in COVID volume and it goes from the mid 90s, back down into the 70s, we would start having that conversation again. Okay, when can we get back to doing these surgeries again? So a lot goes into it, staffing, as well as, staffing illnesses, the overall shortage of healthcare workers. I think everyone's experiencing, and then the volume or the total amount of COVID patients that we have in our system.
Thank you, Dr. Hooker. And of course, we will communicate that once we are ready to resume those surgeries. So be on the lookout for that communication as well.